The following podcast is part of a certified educational activity titled Translating Data into Practice, Examining the Impact of Weight Loss Pharmacotherapy on Cardiovascular Outcomes. Access the entire activity and complete the post-test at peerview.com/UGE860. Downloadable slides and practice aids are also available.
I'm Dr. Darren McGuire, a general cardiologist at the University of Texas Southwestern Medical Center in Dallas. I'm a clinical trialist, having worked the last 25 or so years in cardiometabolic disease clinical outcomes trials. And I'm pleased to be able to bring to you today some updated information about some outcomes trials in the space of obesity. So for the first time, we're actually having clinical outcomes and efficacy demonstrated. Our goals for today are to summarize the relevant data from the European Society of Cardiology and the American Heart Association 2023 scientific sessions, where two large clinical outcomes trials have been presented. And we'll show how these data place the management of cardiovascular risk in persons with obesity firmly within the cardiologist's wheelhouse, and to encourage implementation of these new findings into clinical practice. More than half of the world adult population is projected to have overweight or obesity by 2035. That's just over 10 years from now. We'll be dealing with half of the adults in the world with this long-standing morbid and mortal condition. High BMI is associated with increased and earlier mortality risk, with greater than 2/3 of deaths in persons with obesity and overweight are due to cardiovascular disease. The effects of lifestyle or pharmacologic interventions for overweight or obesity until recently on cardiovascular complications remains largely unknown. Over the last couple of years, we've had a number of medical therapies being developed for the treatment of obesity. We have two in the U.S. approved for the treatment of obesity. Those are the leftmost two demonstrated on this slide. That's the high-dose semaglutide, 2.4 milligrams, once weekly injectable, and tirzepatide, 15 milligrams, once weekly injectable. Tirzepatide, just in the last 3 to 4 weeks, achieved FDA approval for the treatment of obesity. So we have these two on the left, but over the last 6 months, since the American Diabetes Association scientific sessions in June of 2023, we have a number of reports in the peer-reviewed literature showing early phase 2 data on a number of novel therapies that are combining multiple different avenues of incretin modulation. Survodutide, which is combining a GLP-1 receptor agonist with a glucagon receptor agonist, on average in their early development program, have demonstrated an average 12.1% body weight reduction. Retatrutide, this is a triple agonist combining GLP-1 receptor agonism with GIP and glucagon receptor agonism as well, the most potent pharmacotherapy we have ever seen to date, an average weight loss of 22%. Very remarkable, and ongoing trials are studying further the different populations, and ultimately will be tested for cardiovascular outcomes. A very early phase 1 report from a compound, a dual agonist that's administered once monthly injectable, which is now named AMG-133. This yields a 15% average weight reduction. And then finally, we have two oral formulations pushing the needle above 10% average weight loss. A semaglutide oral at a much higher dose than presently approved. Oral semaglutide currently is approved for the treatment of type 2 diabetes at 14 milligrams once daily. Now studies have demonstrated a much higher dose of 50 milligrams once daily achieves weight loss that mimics the injectable semaglutide dose that's approved for use. And then orforglipron is another non-peptide GLP-1 receptor agonist, again having a very similar weight reduction, average 12.4%. What's demonstrated in the far right is what we expect to achieve on average with sleeve gastrectomy. So some of these medical therapies are approaching bariatric surgery level weight reduction. And the horizontal red dashed line is the FDA regulatory requirement that drugs to be approved or considered for indication for the treatment of obesity are required to have at least an average of 5% weight reduction. As you can see, every agent on this slide has an average greater than 10%. So really moving the needle for efficacy in this disease state. And just to remind you that obesity is a disease, and it's a long-standing chronic disease with multiple comorbidities. Up until recently, we've targeted the individual comorbidities like hypertension and dyslipidemia, physical inactivity, but now on top of all those therapies, we're seeing efficacy for cardiovascular risk reductions that we'll dive into reporting these two trials. First, we'll talk about the STEP-HFpEF trial. This was presented at the European Society of Cardiology. This was a patient population of over 500 persons greater than 18 years who had a BMI greater than or equal to 30 kilograms per meter squared. All of these people had heart failure with preserved ejection fraction, defined by an ejection fraction greater than or equal to 45, and at least one additional objective measure of heart failure, so elevated BNP or left atrial enlargement or left ventricular hypertrophy, for example. This trial excluded persons with diabetes, and so this wasn't a patient population with obesity but without diabetes. They were randomized to be treated with the weight loss formulation of semaglutide 2.4 milligrams once weekly versus a matching placebo. As is done with all GLP-1 receptor agonists, there was a 16-week dose escalation. This is done for all of these agents to avoid or minimize the GI side effects that are common with these drugs at initiation, but almost always go away and almost always are tolerable to get titrated to the maximum dose. So the ultimate dose is 2.4 milligrams once weekly versus placebo. This trial had dual primary endpoints: the change from baseline in KCCQ, that's the Kansas City Cardiomyopathy Questionnaire, clinical summary score, and also change in body weight from baseline. Confirmatory secondary endpoints included 6-minute walk distance, a hierarchical composite analyzed using a win ratio methodology, and change in CRP. Just an overview of who was in this trial. Again, 529 participants, 56% were female, 69 years old on average. The median BMI at study entry was 37, and 2/3 of the participants had a BMI greater than or equal to 35. So this was a truly an obese patient population. 7% were Hispanic or Latino, only 4% Black. So it would have been nice to have a more racial and ethnic diversity, but this is what the trial enrolled. Over 80% had prevalent hypertension. Over 50% had atrial fibrillation, again underscoring the concomitant risk of atrial fibrillation associated with obesity. And almost 20% had prevalent coronary artery disease at baseline. The median N-terminal pro-BNP was just over 450 at baseline, and a median CRP was elevated at 3.8 milligrams per liter. Again, anything greater than 2 milligrams per liter is considered an elevated CRP for cardiovascular risk prognostication. The average ejection fraction was 57%, with 66% of the participants having class 2 symptoms for heart failure. Over 80% were being treated with diuretic therapies, including 35% on mineralocorticoid antagonists, over 80% on RAS inhibition, almost 80% on beta blockers, only 3 to 4% on an SGLT2 inhibitor. And again, this is a HFpEF patient population enrolled during a time in which SGLT2 inhibitors were just entering the guidelines for the treatment of left ventricular or for heart failure with preserved ejection fraction. Lastly, 15% of the participants had a heart failure hospitalization within the prior year. This is the first of two dual primary outcomes. This is change in body weight over a median follow-up of about 36 weeks, a total of 52 weeks of observation. And the end of treatment difference between the two groups was an average 10.7% difference in body weight reduction associated with the semaglutide 2.4 milligrams once weekly. So a positive trial with regards to this first primary outcome. The second primary outcome is the change in the cumulative summary or clinical summary score of the KCCQ. And again, this is a score from 0 to 100, with higher being better. And a clinical change in this score of 5 or more points is considered clinically important. And in this trial, it was observed almost an 8-point increase in the clinical summary score. So this is remarkable. This is the largest change in this score that we've seen in the setting of heart failure with preserved ejection fraction. So a remarkable, a clinically relevant improvement in symptoms of heart failure for these persons living with obesity who have heart failure with preserved ejection fraction. The exploratory confirmatory outcome of 6-minute walk test, the participants on semaglutide had a 20-meter increase or above placebo increase in their 6-minute walk distance. Again, this is a significant finding and is among the greatest changes in 6-minute walk distance we've seen in this setting of heart failure with preserved ejection fraction. Interestingly, BNP went down with semaglutide. This underscores the likelihood that not only is this the weight loss that's causing the people to feel better, but also some mitigation of heart failure, helping the persons feel better. With weight loss, we have seen in the past BNP go up as weight is reduced. We know that adiposity falsely reduces circulating N-terminal proBNP. And so with weight loss, we do run the risk of having heart failure get better, yet the BNP not change or maybe even go up. So it's a very impressive finding that there's a statistically significant greater reduction in N-terminal proBNP with semaglutide than was observed with placebo, underscoring again the likelihood that in addition to the weight loss, that heart failure was actually improved with this intervention. These are data simultaneously published in a secondary publication from the primary paper. This was published simultaneous with the presentation in Nature Medicine. And this is changes in the KCCQ clinical symptom score, as well as the 6-minute walk distance based on stratification by weight loss achieved. And what you can see in the top is the more weight loss that was achieved, proportional. So going from the top less than 5% to the bottom greater than 20% weight loss, there is a graded association with improvement in the clinical summary score. So the more weight loss that it was achieved, the better the person's reported feeling, and that makes sense. They're aware of their weight. They do feel better. It's again a combination of the weight loss plus some improvement in their heart failure symptoms. There's also a graded association with 6-minute walk distance improvement, although it's not as graded as we see with the symptom score improvement. But again, a clear correlation between the magnitude of weight loss and the improvement in symptoms and function. Here we see stratified by baseline clinical summary score. So there's really no difference. Wherever you start, you get the same relative magnitude of improvement, whether we're looking at the KCCQ clinical summary score, or if we're looking at 6-minute walk or change in body weight. So pivoting now to the second important large trial that's recently been reported. This was just a few weeks ago at the American Heart Association. This was the results of the SELECT trial that evaluated semaglutide at the obesity dose 2.4 milligrams weekly versus placebo on cardiovascular outcomes. Participants in this trial were age greater than or equal to 45 years old, had a BMI greater than or equal to 27, so including persons with overweight and with obesity. The hemoglobin A1C less than 6.5. This trial excluded diabetes, persons with diabetes, and everyone entering this trial had prevalent atherosclerotic cardiovascular disease, so prior MI, stroke, and or peripheral arterial disease complication. So this is a proper atherosclerotic cardiovascular disease outcomes trial. Over 17,600 persons were enrolled. This is the largest obesity trial ever conducted. The trial was designed to capture at least 1,225 MACE events, MACE being defined as a time to first occurrence of cardiovascular death, myocardial infarction, or stroke. So a classic gold standard 3-point atherosclerotic cardiovascular disease outcome. This trial enrolled, again, over 17,600 persons. 3/4 of the participants were male, 61 years old on average. The mean BMI here was 33. 11% had a BMI greater than or equal to 40 or stage 3 obesity. So a fairly diseased population when it comes to body mass. Over 80% had hypertension. 3/4 had a prior MI, so very high risk patient population. The average A1C was 5.8. Remember, patients with diabetes were excluded. 2/3 of the persons enrolled in the trial had what is considered pre-diabetes range hemoglobin A1C in between 5.7 and 6.4. So perturbed glucose metabolism, but not achieving the threshold for diabetes diagnosis. 1/4 of the patients had heart failure at entry, ranging from New York Heart Association class 1 to 3 symptoms. 13% had heart failure with preserved ejection fraction, and 8% had heart failure with reduced ejection fraction. Almost 11% had an eGFR less than 60. Over 90% were on some antihypertensive medication, almost 90% using an LDL lowering medication, 85% on an antiplatelet medication. 1/3 were taking diuretic therapy, 20% using anti-anginal medicines, 13% on antithrombotic medications other than antiplatelets. So this is vitamin K antagonists and direct oral anticoagulants, and just over 3% using any antiarrhythmic agent. On average, these were reasonably well controlled with regards to cardiovascular risk factors. Average blood pressure is 130/80, total cholesterol of 153, LDL cholesterol of 78, HDL cholesterol of 44, and a triglyceride of 135. These are the primary results for the 3-point cardiovascular MACE event: cardiovascular death, non-fatal MI, and non-fatal stroke. There were over 1,200 events accumulated, a statistically significant reduction in 3-point MACE of 20% with a p-value less than 0.01, and again, a 1.5% absolute risk reduction over 48 months of follow-up. This is the second prioritized outcome of cardiovascular efficacy. This is death from cardiovascular causes. This failed to achieve statistical significance, a trend towards a 15% relative risk reduction with an upper confidence limit just above unity of 1.01 and a p-value just above the nominal p-value 0.05 here, a p-value of 0.065. And this is based on 485 events, so a fairly substantial number of events to analyze and just missing a statistical significance. Cardiovascular death or hospitalization for heart failure or an urgent visit for heart failure. This is a combined composite outcome of heart failure related outcomes. And again, over 660 events accumulated. This did achieve statistical significance and 18% relative risk reduction because it was down in the hierarchy following the cardiovascular death that did not achieve significance. No p-value is provided, but you can see from the 95% confidence interval that this achieves a nominal significance of less than 0.05. All-cause mortality, importantly, a very impressive single component outcome here, a 19% relative risk reduction in all-cause mortality, and again, achieving nominal statistical significance with a confidence interval excluding unity with a point estimate of 0.81 or 19% relative risk reduction. This is almost a 1% absolute risk reduction over 48 months in mortality. Important to note a few individual outcomes. Non-fatal stroke actually did not achieve statistical significance and barely in the right direction, 0.93. This is important to note as the meta-analysis of this class of medications, one of the most consistent findings across the cardiovascular outcomes trials in the diabetes space has been a consistent reduction in stroke events. And here we do not see that. It's likely driven that these persons do not have diabetes, which clearly increases stroke risk. And on average, these patients are younger than we've studied in the type 2 diabetes setting. And so I'm probably at lower average risk of stroke to begin with. Importantly, heart failure alone, hospitalization or urgent visit for heart failure, a point estimate that's similar to the overall trial finding, a 21% reduction that does not meet statistical significance, but is qualitatively in a similar direction. And again, the composite heart failure outcome did achieve statistical significance. And then importantly, very little is published in the primary manuscript, and we look forward to seeing these data in more detail. But nephropathy composite, this is a sustained reduction of greater than 40% of EGFR, kidney-related death, or renal replacement therapy. This is a statistically significant reduction in the progression of non-diabetic kidney disease. And of course, there was weight loss reduced with semaglutide 2.4 milligrams. On average, at the end of study, end of treatment difference, there was an 8.5% greater average reduction in weight with semaglutide than placebo. And on the right, you see waist circumference was reduced by over 2 inches of waist reduction, a placebo subtracted difference of 6.5 centimeters of reduction in waist circumference. Some metabolic endpoints of interest, prevention of diabetes in the first line, maintaining a hemoglobin A1C below 6.5 was more common with semaglutide than with placebo. So 12% of placebo-treated patients progressed to a diagnosis of diabetes versus 3.5 in semaglutide. That's a 73% reduction in progression to diabetes. Also, for persons who entered the trial with abnormal hemoglobin A1C between the 5.7 and 6.4 range, 50% who were normal to begin with progressed to this abnormal hemoglobin A1C of 5.7 to 6.4, whereas only 21% of patients treated with semaglutide. That's a 67% reduction in progression from normal glucose to abnormal glucose below the diabetes threshold. There were favorable effects on systolic blood pressure with an average difference of 3.3 millimeters of mercury, a favorable effect on average hemoglobin A1C with a reduction of 0.3% between semaglutide and placebo. C-reactive protein, impressively, a 38% reduction in CRP. Remember, the average CRP at baseline was well over 3, and so this is a substantial reduction down into effectively the normal range of inflammation. And we know that inflammation is one of the mediators of the complications of obesity, and so its reduction hopefully will translate into further risk reduction for cardiovascular disease. There was a modest reduction in LDL greater than in the semaglutide-treated patients, and also triglycerides were favorably affected with semaglutide. So that summarizes the data. For the first time in my career and in our careers, this becomes a cardiovascular disease. We now have 2 pharmacotherapies shown in 2 different populations, one with heart failure with preserved ejection fraction, another with atherosclerotic cardiovascular disease, the very patients we see on a daily basis. Now we have evidence that persons with overweight and obesity will benefit on top of everything else we're doing with blood pressure control and lipid management. From a cardiovascular perspective, with these weight loss approved type 2 diabetes or weight loss approved non-diabetes populations, in this case with semaglutide 2.4 milligrams subcutaneous weekly, there is an ongoing trial very similar to SELECT, testing the same patient population, effectively testing tirzepatide. And there are cardiovascular outcomes trials now being designed and initiated across a number of the medical therapies I presented on the first slide. So we have a very rich future here, but at the moment we have evidence to support the consideration of using semaglutide 2.4 milligrams weekly for persons who have these cardiovascular risk conditions who also have overweight or obesity. It's been shown that this dose reduces risk for cardiovascular death, MI, and stroke among persons with obesity and prevalent atherosclerotic cardiovascular disease. Semaglutide 2.4 milligrams weekly reduces the symptom burden and improves function among persons with obesity and heart failure with preserved ejection fraction. And little is yet known about the effects on broader outcomes such as atrial fibrillation, obstructive sleep apnea, depressive disorders, work productivity, hoping to get some of these analyses out of the SELECT trial in the coming months to years to really glean the evidence from this large randomized trial to address the totality of the morbidity that affects persons living with overweight and obesity. As mentioned, we have several medications on the market and in development, now averaging greater than 10% average achieved weight loss. This level of weight loss that we anticipate will be translatable into clinical outcomes improvement. And again, for cardiovascular outcomes, this amplifies the imperative for us to adopt these medications in our day-to-day practice in clinical cardiology. We're presently at the beginning of a field of evidence like we were about 10 or 12 years ago with type 2 diabetes, as we were just getting the outcomes evidence, and we're now routinely using SGLT2 inhibitors and GLP-1 receptor agonists for persons with diabetes in the cardiology clinic. These drugs developed to treat obesity will also become part of our day-to-day clinical practice. And we're seeing myriad biomarkers of cardiovascular risk that are tracking the weight loss. And again, ideally, in aggregate, will be favorably affecting not just atherosclerotic cardiovascular outcomes in heart failure, but also atrial fibrillation, blood pressure, dyslipidemia, and all of the other concomitant comorbidities that track with obesity and yield a substantial burden of disease for these patients. A major challenge remains affordability. Presently, these drugs are over $1,000 per month retail. As we get evidence for cardiovascular risk reduction, anticipate incremental coverage by third-party payers. Now that we have cardiovascular outcomes to do some cost efficiency analyses, but to payers, to patients, and to society, the affordability and accessibility remains a major challenge, and hopefully we'll continue to make improvements on that front. So that concludes our discussion for today. Be on the lookout for 2 companion activities in this educational collection that will provide additional insights on the latest clinical data from ongoing trials of medications for obesity. I hope you found this activity informative and useful to your practice, and encourage you to participate in the other activities that are part of this curriculum. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UGE860. This activity is supported by an educational grant from Novo Nordisk Incorporated.